Absolutely. So I think we have a long way to go with treatment for relapsed refractory multiple myeloma. We've made some progress, right? CAR-T and cilta-cel, the data from CARTITUDE-1 are amazing, but we have work to do. So I think I can break those treatments into two categories: new CAR-T therapies versus everything else, for lack of a better phrase. For new CAR-T therapies, I think a lot of exciting work is being presented here at IMS. For example, just to showcase one example, Dr. Ball yesterday presented posters about arlo-cel, arlocaptogene autoleucel, is the GPRC5D targeted CAR-T cell therapy. I think the biggest thing that my takeaway from it, and one, that it works very well in its own right, and two, most importantly, that it works equally well in BCMA-exposed patients versus BCMA non-exposed patients, and CAR-T exposed patients versus CAR-T naive patients. You may say, well, duh, because it's not targeting BCMA, it's targeting GPRC5D, and I would say yes, but also, historically, we've always wondered about these patients when they have post-CAR-T relapse. Is it because their T cells are exhausted? Do they have more aggressive disease biology? Because historically, when we've looked at the data for BCMA after BCMA, even if it's years later, patients who are BCMA exposed do worse. And it may be, again, BCMA mutations, maybe T cell exhaustion, maybe just confounding that the patients, again, who have the most aggressive disease biology are the ones who are going to have a relapse after CAR-T, moving nothing different. Long story short, it's the target, BCMA. So if you use a different target, GPRC5D, it works just as well. I'm very happy to see that. There are a lot of data presented here about other novel bispecific antibodies and small molecules, for example, mezigdomide, cemsidomide, et cetera. I'll give one intriguing example that we can't say anything definitive from it, but it's really intriguing. Data at the late-breaking abstract by Dr. Adam Cohen and colleagues at the Penn Group looked at a study of giving cevostamab to patients after ide-cel or cilta-cel. The idea here is that we typically have put all of our eggs into two baskets to a fault. Almost all of our treatments in the immunotherapy domain have been either BCMA or GPRC5D. Arlo-cel is also GPRC5D. There's a third bucket here, FCRH5, and they tried giving this bispecific antibody, an FCRH5 antibody, cevostamab, to patients within a couple of months of CAR-T. And there were worries that it might cause weird T-cell activation, cytokine release syndrome, et cetera, or may cause a lot of side effects. A lot of patients, even 3 months after CAR-T, are having issues with low blood counts, et cetera. None of that happened. Very well tolerated after CAR-T. There were some interesting, autoimmune phenomena. Hard to say whether the CAR-T did it or cevostamab did it or bad luck. But basically, cevostamab was very well tolerated after CAR-T. We know that some patients, when they have a relapse following CAR-T therapy, the seeds of relapse are there almost immediately. Like within 1 month, if we had all the diagnostic tools available to us, we'd be able to tell that relapse is brewing. Some have argued that you even can tell from the contents of the leukapheresis bag, of the actual contents of the CAR-T cells, how many are CD4, CD8, regulatory, how exhausted they are, that even from that, the moment the CAR-T cells go in, the patient's fate is sealed. Drugs like cevostamab are showing, well, maybe the patient's fate isn't sealed. Maybe there are things we can do. We don't know yet, but maybe this will be one of the strategies where if someone is at high risk of relapse after CAR-T cell therapy, based on everything we know so far, what if we give them a T-cell engager afterwards to kind of shake things off and prevent relapse from happening, delete those cells that are about to start relapsing? Wonderful principle, really exciting work. We need more just research and longer follow-up to know for sure.